This is QD Clinic. I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live, February 8th and 9th, coming up in 1 week. You know, if you register as a virtual participant, you get to download all the lectures, all the slides, all the pre-learns, all the pre-test learning. You get to receive the board questions that were from last year's meeting and from this year's meeting. Last year, I think we had 165 board questions generated from our meeting, from our speakers. And again, you have access to all the materials. And as a registrant, you can look at that material for up to 6 months. So you can be there all day Saturday, but Sunday, you got a christening to go to. It doesn't matter. You can go back and look at Sunday's content at your leisure. Check out RheumNow.live at RheumNow.live. Today's case is recurrent oligoarthritis. This is a 40-year-old male who is here for recurrent acute, usually left knee swelling, but today he's got bilateral knees that are swollen. A year ago, he had an acute onset of joint pain. He said that he had a metal splinter that went into his left knee. He must have just remembers having that splinter. He never had surgery to have it removed. It never showed up on an x-ray, but he said that got infected, and he was treated with antibiotics, and the antibiotics made him better. But a year later, he presents to his primary care with acute left knee swelling, the same knee, by the way. And he has intermittently been treated with antibiotics, nonsteroidals, and steroids. He denies any trauma to this knee. He denies any fevers, rash, inflammatory eye disease, bowel disease, or STDs. He has an occasional right Achilles tendon pain. He has no other significant past medical history. When you see him today, he is complaining of fatigue and heel pain. And since this all began, he's gained about 10 pounds. He doesn't exercise. On exam today, he has 1+ effusions in both knees, worse on the left. There's some mild warmth in the left knee compared to the right, but they're both a little bit swollen. He is tender along the right Achilles insertion. His tender joint count is 2. His swollen joint count is 2. His clinical disease activity index is 13 when you factor in his hack and his pain level. His spine exam is normal. When you look at the notes from prior orthopedists, they withdrew fluid at one time, 100 cc's of serosanguinous fluid with a 32,000 white count. But he had a normal CRP at that time, and all other tests were normal. When we saw him, we aspirated about 60 cc's of fluid. The white count was 8,500. Mostly polys. All his lab, CBC, chem profile, sed rate, rheumatoid factor, CCP, Hep B, Hep C, B27, quantiferon, uric acid were all normal. However, his CRP was elevated at 4.6 milligrams per deciliter or 46 milligrams per liter. So what is this? This is an inflammatory oligoarthritis that recurs. You know, you could say this is palindromic rheumatism. Why not? They don't have to be rheumatoid factor positive. He's got bilateral joints. This is palindromic rheumatism. And if you've been following me from ACR or this year, we've talked about palindromic rheumatism as being a category that fits under the diagnosis of preclinical RA or clinically suspect arthralgia. Does it not? So that's one thing. This could also be an adult presenting with the teenage equivalent of B27 positive spondyloarthritis with an oligoarthritis and an ANA sometimes. He doesn't have an ANA. Well, he happens to be B27 negative, and he is ANA negative as well. He does respond to steroids. So in addition to giving him Depomedrol intraarticularly, we gave him 10 milligrams of prednisone to take for 3 weeks. You know, immediately he was better with the intraarticular injection. He only got one, by the way. He said both knees went down. But he was also on prednisone. And then 3 weeks later, he had no arthritis and no complaints and was back and being active. So the question is, what happens when he returns with yet another swelling? I've had a dozen of these young folks, and they tend to be more male than female. They tend to be always oligo. They almost always are large joint, not small joint. Small joints give me worry. Small joints I'd be biopsying and looking for strange atypical mycobacterial infections or fungal infections. But in this gentleman, he's had repeated synovial fluid cultures, including for AFB, that were negative. So the question is, what's the diagnosis? And I'm going to tell you, the most likely diagnosis in this man is no diagnosis. You keep treating him intermittently until this goes away, until he doesn't come back. And that's usually the case, especially in the males. They're kind of nomadic. They don't show up. They come once, twice, 3 times, and then that's it. And then you're left wondering, did I cure him? I like that version. Or did he go to someone across town and speak ill of me? Well, across town, I'm sure my buddies would defend my honor. But nonetheless, most people don't have a diagnosis. The next most likely diagnosis here, I think, still is SPA, more so than clinically suspect arthralgia, maybe going to become RA, because this is now going on for 2+ years. So if that's the case, you could, if he keeps recurring and having recurrences of more than 2 a year, start thinking like it's gout. If it's more than 2 a year, shouldn't you be doing chronic prophylaxis in gout? Let's do the same in this gentleman. By the way, synovial fluid was negative for crystals, both calcium pyrophosphate and monosodium urate. So in that case, I would offer this man an IL-17 inhibitor, a TNF inhibitor, and Otezla or apremilast. Yes, I think that works just as well here. Why not? And then you could use methotrexate if that's what you prefer. But you certainly have options if this goes on into a 3rd and 4th year and he keeps coming back to you saying, please, Dr. Cush, you got to help me. I'm tired of these happening at inopportune moments before I'm giving a big board presentation, or I'm traveling on vacation, or I'm going to my daughter's, or my niece's wedding or whatever. I think you do have treatment options here. The problem here is most of these young folk tend to not come back, and you may not know the answer ultimately. But stick around as long as me, and you'll develop a body of evidence as to how to treat them. I have, in some instances, treated them as if they were reactive arthritis and gone with 6 to 9 months of chronic antibiotics. That was no more effective than intermittent steroid use, no more effective than chronic suppression with a DMARD. There is often no right answer. The right answer is being concerned and following up and giving them your cell phone and telling them, come see me when you get a flare-up. Let's nip it early in the bud. Let me see you when you're at your worst. That's it for QD Clinic. We'll see you at RheumNow.live.